Hey, so we're going to talk through the examination process and some of the general concepts that we find are very important with the exam. So to start with, one of the major things that we're going to be addressing when we look at the spine is biomechanics. And so what we're talking about in this area is the fact that parts of the body work together to perform or produce normal movement. So we've got forces that are acting through the body, and our body is able to account for those forces and sometimes even compensate for those forces to create normal movement. Now, we do have episodes of pathomechanics, and so this is basically like pathology-related biomechanics. And an obvious example of this would be a player on the field sprains their ankle and then they start limping off the field. So that is obviously an example of pathomechanics. We also have examples of aberrant movement patterns, which means it's not such an overt example of pathology related to biomechanics of the body, but it's more just slight, can be more than slight sometimes, but slight aberrant movement patterns, kind of like this person right here. If you watch him, he's doing some trunk side bending, and what we're really looking at is the direction of movement to the right. And also look at when he does it repetitively, which is kind of interesting. So there are times when even just the slightest aberrant movement patterns can over time create pathological biomechanics within the body. So look, we're getting some trunk extension here. He's getting a little bit of rotation to kind of account for that issue that he's having with right side bending. We don't know what that is unless we could get our hands on him. But definitely you can see the quality of that movement is different from side to side. And so that's something that you want to pay attention to. In terms of importance in the examination process of differential diagnosis, this is very important. And so one of the things that you're going to want to do is generate a problem list. And that's basically just what are the likely possibilities that are going on with this patient. So I usually generate these starting with my most probable diagnosis or diagnoses, and then kind of in decreasing likelihood create my list. So is it always necessary to come up with a specific diagnosis? It really isn't. So there are times when the specific diagnosis doesn't affect your treatment. There are times when you do need to have a specific diagnosis. So like in a lot of cases with working with patients, it depends. So it depends on how that patient's presenting and what you're looking at. But no, a specific diagnosis is not always necessary in order to treat that patient. So one of the things I do want to bring up is this ICF model. So this is the International Classification of Functioning. And what this does is it basically calls to mind and reminds the practitioner to relate the patient's disorder or disease process that they have going on to not only how that's affecting their body functions, but also their activities that they're able to perform, and also their participation, meaning are they able to carry on their role on their sports team? Are they able to do their role as a parent or as a worker? So it reminds you that patients don't operate in a vacuum. You know, they have lots of other demands that are placed on them, and their particular injury can have a fairly significant impact on their life in a lot of different ways. And so it is important for us to ask our patients, what activity can you not do? What do I need to help you get back to doing? So it reminds the patient that we're there for them, that we're very specific to them, and that's a lot more meaningful than me saying, oh, I need you to regain your shoulder range of motion to 170 degrees of elevation. That's meaningless to a patient. But if I say, okay, you need to be able to play tennis with your kids and not have your shoulder hurt, then that means something to them, and it shows that we're keeping their, their needs foremost in terms of our treatment plans. So always be sure to ask your patient what's important to them. This calls into mind just, again, that concept of biomechanics and the fact that we have regional interdependence within the body. So when we have even slight aberrant motion or aberrant movement patterns, it can cause stress along the pathway. So we know that everything's connected, and so things that affect your feet are going to be transmitted on up the kinematic chain. And, that's important to remember, but it's also important to remember that this is all potential. So it doesn't necessarily mean that that person can't accommodate that stress. So different patients are going to be able to accommodate stress better than others. And I'm sure you've seen videos of amazing runners who, do amazingly well for their running careers, and they have some of the most interesting gait patterns when they run. And you'd never dream of fixing that because it's obviously working for them. So it calls into mind here, it's not always something that needs to be fixed. So you need to take each person individually. So there's the potential that it could be creating stress along the chain. And there's a potential that, hey, they're running, 15, 20 miles a week. They've done this for the last 10 years. They don't have any trouble. I don't know. If it's not broken, don't fix it. So it all depends on how that patient presents. In terms of examination technique, it is important to have a system and to kind of use that system every time that you see a patient. It makes you more efficient. Use your time wisely because we're all in a time crunch. And we're going to include not only objective data, so this is basically like reproducible information that should be fairly consistent no matter who is doing the testing. And we're going to want to take baseline measures, so measurement when you first see that patient, so whether it's acute, like an on-field examination, or whether you're in the clinic or training room, and then consistent and scheduled reassessments periodically to assess progress, and then obviously make changes as needed. You're going to want to document what you do. That's a medical or a legal requirement for us to document all medical procedures. So there's that. It is important to consider the role of the non-injured limb. And, we may not see this quite as much when we're working with the spine, but this certainly applies to a lot of aspects of treatment. So I think it's a good practice to assess the uninvolved limb first so that you can get a sense for the way that that patient presents, whether it's in terms of muscle strength or laxity or, apprehension, and then to test the injured limb as your second one, okay? And I think this helps patients to kind of get used to what you're going to be doing to them, and it decreases their apprehension. So when you're starting the examination progress, history is really important. So you're going to want to take a past medical history. And a lot of times we do this through like an intake form where you have patients or maybe their parents fill out past medical history. And then history of present condition, or I also call this history of present illness. And this is basically where you ask about mechanism of injury, pain complaints, how is it affecting them currently. You talk about kind of the temporal component of their pain or dysfunction. How does it change during the day with activities that they're doing? So a functional assessment is very important because this this can take the place or take the form of a written assessment. So like the oswestry or the Neck Disability Index are two that are specific to the spine that we use in the clinic a lot. Also the FABQ is a functional index. It's a little bit different. It looks at fear, avoidant behaviors. And then we can also look at just functional movement patterns of the body to see how different components are going to work together or how they're not working together because of injury. So we'll do a lot of functional movements to assess how patients are doing with that. Okay. This just talks about some of the specific components of the physical examination. And the key point here is basically how the non-injured limb is providing a reference point for the injured limb. Okay, so you can compare joint stability, you can compare your vascular screen, your manual muscle testing, special testing. Always compare side to side. That's going to be your best way to figure out, hey, is this normal for this person, or does this feel different than their uninvolved side? So that's really the best way to compare. In terms of your clinical assessment, so obviously doing an assessment in the clinic that is not acute is going to be very different than an acute on-field evaluation. So we're going to look at things a lot more thoroughly and probably going to be a lot more detail. On the field, it's basically just kind of gross assessment of whether things are intact or not. And when you're in the clinic, it's going to be a lot more quantifiable information. So some things to consider when you're working with your patients in the clinic. Discretion, obviously you want to drape patients as appropriate. People have varying levels of privacy, and we always want to maintain patient privacy. So, pull the curtains around, have your patient draped with a gown when appropriate, take the extra time to make sure that they're comfortable in the clinic and with the physical examination. Any kind of religious considerations, sometimes we're going to run into opportunities to take these into account when we work with patients of different backgrounds. And I've always found the best way to, to be able to talk with patients about any kind of special religious consideration that we need to take into account is just to ask. So patients are very open. So whether it's the athlete that you're working with or a family member, just ask. And they're always happy to help if there's anything in particular that you need to know about. Obviously, informed consent is always important, so we're always going to have a consent to treat. If it's an acute type of situation, then consent is implied, and you would obtain informed consent at a later date in the clinic as well if you're going to continue with treatment there too. In terms of history, so history is going to be really important because this is how you're going to identify the mechanism of injury, any sort of past medical history that's relevant to your patient, possibly any underlying pathology. So maybe if the patient's had an injury affecting this body area or even another body area in the past, that could create kind of a pervasive or chronic weakness that is now translated to a different injury. So don't always assume that something's unrelated. A lot of times patients will come in and they'll say, well, I didn't think my hip pain had anything to do with what's going on with my knee. I mean, that was my hip. Well, it could. And so I always tell patients just to, kind of tell me everything. And then I'll kind of make my way through it to see what's important or not. This is where it's important to ask open-ended questions because you don't want to just stop the patient at yes or no. So you want them to just explain to you in their own words how it's feeling and what's been going on with it. And again, this is past medical history specific to non-acute, not on-field examinations. This is going to be more clinic-based, but you're going to want to know previous injuries, any sort of previous surgeries, any relevant family history, like connective tissue disorders, or things like that, and any kind of health condition that might affect your patient at that point in time, or that maybe has affected them in the past. Okay, and so this is also some specific things about the previous history. So, asking your patient, have you hurt this particular area? Have you hurt anything around this area? Compare this to the last time you hurt it. If there is a history of symptoms in that same area, does this feel different? Does this feel the same? What types of treatment did you have for this before? Was the prior treatment effective, or did it not help at all? That's all going to be information that you're going to use to help gear you or lead you in the right direction. So, in terms of overall medical health, you're going to want to know, just general medical health. Are you generally a healthy person? Do you have a lot of chronic comorbidities that might affect treatment? That sort of thing. If they're waiting on lab work to come back, that might affect your treatment. Always keep an eye out for that. And that's where, good communication with their physicians is going to be key, so that you have access to information like that you may not otherwise have. Medications are going to be significant. I had a patient come in a couple weeks ago with symptoms of vertigo, and we kind of ran through our normal evaluation and nothing was really standing out. And so I started to ask him about his medications, and he was on quite a few medications. And so my next step with him was to send him back to his pharmacist to say, hey, are any of these interacting, and could they be causing just kind of this diffuse sense of, he would describe it as light dizziness. So he actually came back. I saw him in the clinic this week, and he said that the pharmacist, he was on medication the pharmacist wasn't even aware of, because he was getting them from different pharmacies, which is something you also have to watch out for. And they are working on kind of fine-tuning his medications so that maybe there's less interaction. So we're going to continue to monitor him, but that, might be something that impacts what we're doing as well. And then obviously, like extracurricular activities like smoking, vaping, excessive alcohol use, that sort of thing is something that you want to be aware of, because it can affect healing, tissue healing. And so if someone's coming in after surgery, those are things that can affect their treatment plan. In terms of history of present illness, I usually say history of present illness. I believe your book refers to it as history of present condition. So I've put both, but I usually say HPI, history of present illness. So specifically looking at the mechanism of injury. So is it a macro trauma? Did they fracture a bone? And so now your patient's laying there with a broken arm or a broken leg. That's pretty obvious. Micro trauma is going to be maybe more microscopic changes that are happening within the body, and that maybe could happen over time as opposed to an acute onset. So asking the patient to relate any sort of sound or sensation that they notice at the time of injury is going to be helpful to help you isolate the tissues involved. And then also, deciding, is it an acute onset? Is it more of a chronic condition? Is it an acute on chronic? Is it something they deal with for a long period of time and then periodically have these flare-ups? That helps you determine how you're going to treat. In terms of pain, there's a lot of different pain questions that we want to ask. So having this type of pain questionnaire is always helpful, so that you can document pain level. You want a number. You want patients to describe the type of pain, because that can have an indication of the type of structure that you're going to be addressing. And also, it's important to get, pain patterns. Does it always hurt when you wake up in the morning? Does it always feel better after you warm up and start doing a little bit of exercise? Does it feel worse after you finish your work day? Is there anything that you can do that helps your pain feel better? Is there anything that you do that clearly makes your pain worse? So all of that is good information. We want to certainly keep in mind referral patterns for pain, because pain can always be referred. And so when we have internal structures that refer somatically, that is something we want to be aware of, just like we want to be aware of radicular pain traveling along nerve roots, especially when we're dealing with the spine. So it's very common to have cervical or lumbar radiculopathy. So referred and radicular pain is common enough. You need to be aware of it. History of present illness. Again, what have you done for this condition in the past? What's worked for you? Even at home, since this happened, what are you doing? Are you putting ice on it? Do you know stretches to do to fix this? What kind of workout do you do in the gym? What's flaring it up? What's making it better? So affective traits, and this is something that we want to keep in mind with our patients. This kind of ties into the fear avoidance behaviors. So we want to keep that in mind when we're talking to patients about their pain. A lot of things that you should keep in mind is the type of language that we use. You don't want to say that necessarily patients are damaging tissue or that their hips are out of place. In patients' minds, that creates, like, they just kind of take that stuff and run with it. And we always want to make sure that our language that we use with patients is not inflammatory and not giving them something else to worry about. So, we may use that terminology, and we know that, we're not putting their hip joint back into place, but patients don't know that. So we always want to make sure that we're watching our language. And then also keeping in mind patients, limitations, like how is this affecting your daily life, and what type of dysfunction are you having because of it? So in terms of physical examination, we are going to, again, like I did want to point out that it's different. On-field examination is very different than the clinic. So, if it's more of an emergent situation, basically you're just deciding, okay, what's the extent of the injury here? Is it life-threatening? And how am I going to get them off the field or off the court, right? Clinic is going to be a lot different than that. It's going to be a lot more specific. And you have more time to address the issues. So your whole exam is going to be different. Again, functional assessment needs to be meaningful to the patient. And so that's something that is probably not necessarily part of your on-field examination, but it's certainly going to be part of your clinic exam. When you look at the patient, you're going to want to inspect the area of injury and even the area surrounding the injury. So we're talking about, is there edema present? Is there ecchymosis? Do they have atrophy? Is there any sort of open wound or infection that we need to know about? Are they guarding that extremity? How are they positioned? What's their posture like? So you want to get really good at observing your patient to see differences side to side. You can always compare involved with uninvolved limb. And then just their general, demeanor. Do they look like they're in pain? Are they having a hard time sitting in the chair when you ask them questions? Maybe there's another position they'd be more comfortable in. So I always take that into consideration. In terms of the physical examination, basically the goal here is to take all of the information that you've obtained from their history, and now you're going to fine-tune that physical examination, and you're going to say, okay, what do I need to do to rule in or rule out possible diagnoses? And again, we want to develop kind of a working hypothesis, which you could also call like a clinical diagnosis of, okay, I think that it's probably this. This is most likely, based on your history, and now we're going to rule things in and out with all of our special testing and our physical examination. So when you start touching patients, obviously you want to use your standard precautions. Again, this is something that you should be doing all the time. You should always wear gloves when you might be exposed to a patient's blood or body fluids. You should always wash your hands in between patients. You should always clean off equipment and mat tables and that sort of thing. So these are all precautions that you should always adhere to. In terms of the physical examination, I tell PT students all the time when they come into the clinic, you just got to touch as many people as possible. You got to get your hands on everybody, because that's the only way that you're going to feel what this feels normal, this doesn't feel normal, and you're going to be able to tell the difference. So you want to be able to assess tissue turgor, which is kind of like a tissue density. Does this feel like it's got normal turgor? Does it have increased turgor because maybe we've got a tender point in this area, or a patient presents with, I don't know, maybe calcification of underlying muscle because of an old hematoma. It helps you assess kind of the quality of that tissue. So you need to have good palpation skills. You need to be able to visualize in your head where these bony landmarks are, and then be able to go in and palpate them. Assessing for the presence of crepitus, so like that popping, cracking type of feeling, and sound sometimes when your patients move. Assessing tissue temperature, so possibly the presence of edema can certainly increase tissue temperature. Infection would be a red flag for that as well. Okay. When we look at the assessment of joints and muscles, we are going to want to perform these assessments bilaterally. So this is the importance of testing uninvolved side first, because then you get a baseline, and then comparing that to the involved side. So we're going to want to look at a lot of different aspects of joint and muscle. When we look at active range of motion, we're going to want to keep in mind osteokinematics, or the movement of that bone, and the arthrokinematics, or exactly what's happening at the joint itself. So we've got, during abduction of the humerus, we've got the arthrokinematics of roll and slide at the glenohumeral joint in order to maintain the proper amount of spacing between head of the humerus and the acromion, so we don't get an impingement type of situation going on. So you're going to want to look at the quality of movement. You're going to want to look at the quantity of movement. And you're certainly going to want to assess the arthrokinematics of that joint, along with the gross osteokinematics like abduction, flexion, and external rotation, let's say, of the shoulder. In terms of active range of motion, this is basically an assessment of what the patient can do volitionally. How well do they move just by contracting their own muscles? So we want to look at, again, quantity, which we're going to measure like with a goniometer, let's say, and you're going to want to look at quality of movement. So I usually have patients run through active range of motion a couple times, because I'm going to look at different things each time they're doing it. So how well are they moving? Does it hurt? How does it feel? Do they have any sort of compensatory strategies? Like, look at this guy, right arm is elevating, it looks pretty good. Look what he's got going on the left side here. So in order to get this left arm up that high, look how much scapular hiking he's got going on. So he's obviously got some compensation going on that left side, and that gives us an idea of where we need to look next. Okay. For manual muscle testing, this is basically looking at strength testing, and we can isolate certain muscles to look at. And also it helps us determine, is it painful? It gives us more information about their pain. So we're going to want to stabilize the arm or the leg that we're testing, and we're going to apply resistance to the distal part where that muscle attaches. That's the key thing. And then we're going to grade it. So we've got our grading scale from 0 to 5, where we're going to grade manual muscle strength. Passive range of motion, and this is going to be mobility that we look at when patients are relaxed. We need them to be as fully relaxed as they can be, and we're doing the movement. So we're looking at the mobility that's available to them when we take away the muscles, take the muscle out of it. Okay, and so what happens is we can compare this. You're going to want to do your active range of motion first, and then follow that with some passive range of motion, and you can compare the two. So if you have passive range of motion that's greater than your active range of motion, then we can kind of tease out and say, okay, well, maybe the muscles are weak, and so because the patient's got the motion available, they're able to move through that whole range passively, but when I ask them to do it actively, they've only got 75% of that mobility. So we're looking at some sort of muscle weakness or muscle involvement with that. If you have diminished passive and active range of motion, then we can think of something like maybe capsular adhesions or some sort of restriction in the joint itself, where it's not a muscle that's limiting it, but we have kind of more of a global restriction. So it kind of fine-tunes where you're going to look. Other parts of the physical examination are going to look at joint stability and laxity. So we can have certainly patients who are hypomobile, who are less flexible than we would, expect them to be. We have, based on their body type and the type of sport they play and that sort of thing. We certainly have some athletes who are hyper flexible, who are kind of on the other end of the spectrum. One way to quantify this is through the Beighton Index. And I've included the pictures here, and it's basically these 5 tests, and you give patients a rating and or score, and this is an indication of their flexibility, So hyperextension at the elbows and the knees is certainly indicative of increased joint laxity. Doesn't always mean instability, but at least more lax than normal. And we know, some people train like that. And just because they have increased laxity doesn't always mean that they are unstable at that joint. Now, sometimes it does, and then you have to go in and tease that out. But we're going to look at joint laxity through stress testing. So we're going to take that joint and put stress on the ligaments and see how that feels. Okay, so if we're comparing joint laxity with instability, so laxity is going to be basically quantifying the amount of give that joint has, when you feel it. And again, this is where it's really important to get your hands on as many patients as possible so you can see what a normal joint feels like, and then also varying degrees of laxity. Instability is when the joint is having difficulty function under normal stress that it's placed under. So joints can be, or patients can present with increased laxity and still be very stable. But then we have other patients who are going to present with instability, even at varying degrees of laxity. Instability, where basically those particular joints aren't even able to function under the normal stress that they're placed on. Okay, this is how we grade ligamentous laxity. So it's a grade 1, 2, or 3. So a grade 1 would be like a firm end feel, and we're going to find this is true. We're going to go through and do stress testing in the spine. So a nice firm end feel is what you would expect, and we can, if we're able, we can compare side to side to see what that normal feels like for them. A soft end feel means that we've got a little more joint play, maybe a little more than you would expect there to be. And then an empty end feel is a grade 3, and this is the type of end feel that I always describe it to my patients as it makes your stomach turn. So if you've ever done like a Lockman's or an anterior drawer on a patient who is ACL deficient, a very newly ACL deficient knee before their hamstrings start kicking in, and you feel that play, you feel that glide of tibia anterior on the femoral condyles, that is empty end feel and makes your stomach turn. So, okay. In terms of joint play, this is how we're going to assess the arthrokinematic motion that's available at the joint. So this is going to be roll, spin, and glide, and we have a combination of all of those as we run through the osteokinematics with each joint. So with this, we're going to typically measure this as we measure passive range of motion, because they kind of go hand in hand. So we're going to have the patient relax. We're going to place them in loose pack position for that particular joint. And then you're going to want to do some joint, movements in your different planes of motion based on where you felt that they were limited, either during active or passive range of motion. And then special tests. So we got special tests that are available throughout the body, and the spine is no different. So we will have a whole cache of special tests that we're going to do for the spine. And so this is going to be specific. We report them as either positive or negative, and these are going to help to guide further examination and treatment. So in a lot of cases, these are provocation tests. So does this special test create pain in the structure? And if it does, I'm going to think this, maybe SI is the issue. And if this special test doesn't create pain in the SI joint, then I'm going to take a different route. So they basically help us to fine-tune what we're thinking. It's also really important with our patients to do Neuro Screens, and we can divide these up into upper and lower quarter screens. This is how we evaluate sensation and motor function through myotomal testing and deep tendon reflexes. So especially with the spine, where we have the potential of having nerve damage, these are screens that you're going to want to do on your patients, and you're going to want to do a thorough job assessing all of these aspects. So these would be screens that you do on everyone, but especially if someone comes in with nerve type pain. So we're talking either paresthesias or pins and needles. Well, they're paresthesias, hypoesthesia, so a decreased sensation. You are going to want to take a look at this. Any athlete who comes in or patient who comes in and relates any sort of injury to their neck or their back, you're going to want to make sure that you do a neuro screen on them as well. So we'll start the neuro screen with sensory testing. So we're basically testing dermatomes of the upper and lower extremities. You've got a couple resources for this. Again, dermatomal maps aren't perfect, and you're going to see some differences between references. So just have a reference for what you do. You're going to perform it bilaterally, and you're going to do light touch and sharp dull localization. Okay, so having the patient sit, you can do a gross motor or gross sensory assessment when the patient first sits down, and then have them close their eyes and look away, and then identify location where you're testing them. So that's how we're getting the localization too. So going through the same dermatomes, but having the patient tell you where you're testing them. Again, both for light touch and sharp dull. Okay. Second one is motor testing, and we do this through myotomes. So we've got myotomal testing. It's important to test each myotome for the upper and lower extremity. And you're going to hold the contraction for 5 seconds so that you get a good feel for the patient's function, at that level. It is important to note that for each nerve root level, you can have multiple muscles that are innervated by that nerve root. So if one muscle doesn't test well, or if it's weak, then you can test another muscle within that same myotome, okay? And also means that there's a couple different ways to do it. So in terms of reflex testing, you are going to need to be able to do deep tendon reflexes, elicit deep tendon reflexes for the upper and lower extremities with a reflex hammer. It just takes practice to get reflexes, and practice on as many people as you can get your hands on. So if you do see a significant increase in reflexes, so here's our grade here. So a 2+ would be a normal response. A 3+ is what we would call like brisk reflexes. So these are people that, they're kind of fun to work with because they have really easy reflexes to get. And then a 4+ would be a hyperactive reflex with clonus. So you're going to see kind of that clonus response as well. If you see a significant increased response for deep tendon reflexes, you're going to want to suspect an upper motor neuron lesion. If the reflexes are absent or significantly diminished, you're going to want to consider a lower motor neuron lesion. And so that's going to help you kind of delineate between the two. But again, in a lot of cases, if you can't get a reflex on a patient, it's probably user error. And in that case, you could use this Gendrasic maneuver for patients. And this is the one where you either hold they kind of pull their hands apart from each other, and that's going to help you with the lower extremity. Or on the lower extremities, I usually have them like push their feet together, and that will help you get it for their upper extremities. So that's a good kind of tip. Okay, there's your grading. In terms of vascular screening, we're also going to want to do a vascular screen on all of our patients when they come in. So this includes not only blood pressure assessment, because you want to make sure that that falls within normal ranges for your athletes, but also capillary refill. You're going to look at nail beds for both upper extremity and lower extremity, and then peripheral pulses for upper and lower extremity. So for upper extremity, carotid, brachial, radial. For lower extremity, you're going to want to be able to do femoral, posterior tib, and dorsalis pedis. Okay, so those are the main ones. And if you can get a distal pulse, then you can, in the absence of any sort of gross injury in between the two, you can kind of assume that any sort of more peripheral pulses are going to be intact as well. Okay, and so the final thing is just the role of evidence when you're doing your examination. So, definitely using your history and functional assessments to kind of steer you in the right direction. You don't need to do every special test that you've ever learned for the knee to figure out what's going on with the knee. So, 80% of the information should be obtained from the history that you're getting from the patient. And then you have your functional assessment on top of that to help you. And then that's going to guide you in terms of what you're thinking, your hypothesis, and what special tests you need to do to either support or refute the hypothesis that you've generated. So Use your best evidence. This makes your exam more efficient. If you know that a special test is kind of worthless, then, maybe it's not even worth doing. I don't know that I would waste my time on that. So we've certainly got information available now in terms of reliability and validity of special testing, and I think that's important to consider. So it's certainly going to fine-tune your examination process and increase the accuracy of ruling in or ruling out your hypothesis. So, okay, so that's it for examination process, and we'll be in the lab practicing some of these general physical exam aspects, and can't wait to see you next week.